People
I had a
be
blood
interesting
trauma
video.
and developed 3 clock hours of ideal dialysis and zonular dialysis and thereafter significant cataract.
Your case is a bit complicated, and the literature also does not help much. But don't worry, I have a new idea to fix both the defects at one go. Let's discuss what we are going to do.
Okay, doctor, that's very nice of you.
Hoffman pocket is made adjoining the area of dialysis. The needle is passed across the pocket just in front of the ciliary body at the ciliary sulcus. Through the peripheral torn iris from outside inwards and brought out of the eye by railroad. It is passed through the eye of the segment CTR. The suture is guided out through the scleral pocket by passing through the peripheral iris from inside out. The segment CTR supports the subluxated capsular bag, and the iris is approximated to its root by the suture, that is, hangback repair is done. All this by a single loop of suture, so you can kill both the defects at one go. Just removing your conjunctiva adjacent to the dialysis.
Basically, this removal of conjunctiva was not much required.
I'm making a Hoffman pocket here. First things first, triamcinolone is used to stain up the prolapsed vitreous. I stain your anterior capsule with trypan blue.
Oh, doc, I can't see any light. Is everything okay?
All is well, don't worry, and plug the prolapsed vitreous with cohesive viscoelastics. Now I remove your anterior capsule carefully. Two stab incisions are made adjoining to the area of dialysis. I have fixed the unsupported portion of the capsular bag temporarily with capsular hooks. 23 gauge trocar is placed on the pars plana.
Oops, doc, be careful.
Take it easy. Anterior vitrectomy is done through the pars plana with the cutting port facing the optic disc lest it injures the still intact capsular bag. Irrigation is maintained in the anterior chamber. This keeps any more vitreous prolapse at bay. Hydrodissection and careful bimanual rotation of the nucleus is attempted. Vitreous is removed from anterior chamber also. Nucleus is divided by direct chop. I am removing the nucleus by phacoemulsification. Now that some nuclear mass has been removed and the bag seems unstable, I think it is high time to support the capsular bag by a CTR. CTR is carefully placed in the bag.
Is it all okay?
Oh yes, we are going fine. Now we are going to use the Gotic suture as you are pretty young. I told you that it is off label.
That's okay, doctor.
We enter with the needle through sclera at the junction of 1/3 and 2/3 of the area of dialysis and pass through the outer edge of the torn iris and brought out of the eye through the pupil by railroad technique. The eye of the emerged segment is threaded by Gotic suture. Now we do a similar pass through, this time by a hollow 26 gauge needle. The needle is docked and brought out through the bed of the Hoffman pocket. The capsular segment is now placed in the bag. Oh no, the suture has passed over the iris.
Oh, doctor, what's the problem?
Don't worry, it will be all okay. I will be releasing the returning suture, and this time I will be doing it right. A 26 gauge needle is bent in a bow-like fashion, passed through the bed of Hoffman pocket, and then through the peripheral torn iris and brought out at the incision. The cut end of the Gore-Tex suture, which has been eyed through the Ahmed segment, is threaded onto the lumen of the needle and punched with a needle holder so as to keep it in place as the needle is withdrawn out of the sclera. The segment is aligned inside the capsular bag. The combination of the Ahmed segment, CTR, capsular bag, and the iris is drawn to the periphery and fixed to the sclera by titrating the knot.
What about the IOL?
Oh yes, the multipiece IOL is placed in the bag. I use the multipiece as we can salvage the situation by doing a glued IOL if the need arises. The knot is buried inside the scleral pocket. Conjunctiva is apposed. You're doing fine. You can see 6'9" with 0.75 diopter cylinder.
Thanks, doctor.
To kill both the dialysis at one go.